erectile dysfunction can also be drug induced. So, unfortunately, some of the drugs used to treat problems like high blood pressure can also contribute to erectile dysfunction, but which we'll get into in a little bit. But this can either be a temporary or persistent problem for men. It can be something that happens maybe once in a blue moon, maybe once in a while, or all the time consistently. We all just have an off day sometimes, that happens to the best. But if you start seeing issues more regularly and more consistently, then we want to pay closer attention to what's going on. Okay, so how common is erectile dysfunction? Estimates can vary, but what's known for certain is that its risk increases with age, with up to about 70% of us affected by the time that we reach our 70s. And that can be various types. It can be partial erectile dysfunction, full blown, but it all falls within these statistics. But you're at an increased risk of developing ED when you have other chronic issues like diabetes, obesity, smoking, heart disease. And as stated before, Black men are affected more than others due to experiencing higher hypertension burden than some other groups. That just means that blood pressure can be more severe in Black men, leading to more severe complications. And another reason why all this matters is because it's not just our sexual health that we need to worry about here. If you find yourself starting to experience ED, it could very well be an indicator that something else is going on in the body that you're just not aware of. The analogy is that the penis is like a check engine light for the heart. So if it's something that you notice, if you're noticing some ED going on, then you want to look under that hood and run some diagnostics to see what's really going on because it can point you towards finding some additional issues like maybe underlying diabetes or cardiovascular disease in the making. But with that, I will turn it over to Steve to get into some more of the specifics on why erectile dysfunction happens.
Great. Thank you, Cabell. And before we get into the medications themselves, I wanted to first take a step back and talk about how erections happen, and then what can go wrong to cause erectile dysfunction to occur. Because an erection really depends on three systems working together: your brain and nerves, your blood vessels, and your hormones. When you're aroused, your brain sends a signal through your nerves to the blood vessels in the penis, telling them to relax and open up. Blood flow then surges, maybe even up to 8 to 10 times normal, filling the spongy tissue and creating firmness. Testosterone and your other hormones support that signal and keep the tissues ready to respond. Now, when all three systems work together, everything functions normally. But when one link breaks, the nerves don't carry the signal as well, blood vessels can't open as well or don't open, or hormones themselves are just off or low. That's when erectile dysfunction happens. So what causes these breakdowns? The main cause of erectile difficulty is typically poor blood flow, and the biggest culprit is high blood pressure. You can almost think of your arteries like a network or series of pipes. When you have high blood pressure, it's like running water through these pipes at too much force for too long. That constant pressure starts to damage the inner lining, and over time, that damage leads to stiffness, and narrowing in the arteries, like rust building up inside a pipe. Now, because the arteries in your penis are among the smallest in your body, they feel this pressure damage first, which is why, as Cavell mentioned, we often say that erectile dysfunction is your body's early warning system. If the plumbing is struggling there, it means your whole system is under stress. So controlling that blood pressure is truly what protects your sexual function in the long run. Now, poor blood flow isn't the only factor. Nerve damage from diabetes, low testosterone, and mental health issues like high stress or anxiety can all play a role and are all things your provider will look at if you are experiencing erectile dysfunction. But the big paradox, or really the irony that happens, is that the very medications we use to treat high blood pressure and protect your heart can sometimes interfere with sexual function as a side effect. Cavell will now discuss what some of these medications are next.
Okay. All right, thank you. And with that, I'll get into the relationship between antihypertensive medications and ED. So, not all blood pressure medications are equal in terms of how they affect or contribute to ED. This chart has some of the common medications that are used to treat high blood pressure, grouped by class, with the drugs at the bottom being the least likely to cause ED and increasing risk as we move up in that chart. So the most common offenders here are going to be medications in the thiazide class and some of the older beta blockers. These drugs are associated with the highest risk for causing ED. So the thiazide class includes drugs like hydrochlorothiazide, chlorthalidone, while some of the eight older beta blockers include drugs like metoprolol, carvedilol, and atenolol. And whether or not you've heard some of these names likely comes down to whether or not you've either been on them before or know somebody who's been on them, or you've just discussed them with your doctor before. Then, as we move down the chart, less likely to cause ED than the meds that I just listed, but can still put you at risk, are the aldosterone antagonist class of drugs and a single drug called clonidine. The aldosterone antagonists include drugs like spironolactone or eplerenone. Then finally, at the bottom of the chart, we have the antihypertensive meds that are least likely to cause any issues with ED. These include ACE inhibitors like lisinopril, ARBs like losartan, calcium channel blockers like amlodipine, and a newer beta blocker called nabivolol. And things can get tricky because while all these drugs can and are used to treat high blood pressure, some of them are also used to treat other conditions like heart failure or irregular heartbeat. So you could be on one or more than one of these drugs for those reasons as well. So for the thiazides, beta blockers, and clonidine, the way that they can cause ED or contribute to it is related to how they work in the body. And this includes ways like reducing blood flow to the penis and decreasing nerve signals from the brain that are responsible for stimulating arousal. And a lot of these drugs are very common drugs. So if you're on them or your doctor is recommending them to you, you can always voice your concerns or any issues you may be having with your doctor. If they don't know about it, then they can't really do anything about it. And most of the time, there are options to help maintain your sexual health, but it does involve having that initial conversation. For the aldosterone antagonists, like spironolactone, these are in that mid-tier risk level. These drugs block the effects of male hormone in the body, and that leads to lower testosterone levels. And lower testosterone levels then lead to decreased sex drive and subsequently to erectile dysfunction. Then for the blood pressure meds that can either have a neutral or a positive effect on ED, we have the ACE inhibitors, ARBs, calcium channel blockers, and nabivolol. So there are plenty of good options. The ACE inhibitors like lisinopril are usually neutral when it comes to ED. And that's because they do protect the integrity of your blood vessels, so blood flow isn't compromised when you take these for extended periods of time. The ARBs, like losartan, can actually improve blood flow and have actually been shown to improve erectile dysfunction. So, a lot of the time, if ED becomes an issue after you get started on a blood pressure med, they'll switch you over to one of these drugs to try to help address it. The calcium channel blockers, like amlodipine, these also help to relax the blood vessels, which results in better flow. And the newer beta blocker, nabivolol, it can improve ED because it actually stimulates the release of a substance called nitric oxide in the blood vessels. And nitric oxide plays a very important role in causing the erection in the first place by relaxing those blood vessels for more blood flow. And then I also wanted to touch on some other non-blood pressure medications that are also really commonly prescribed, but can also contribute to ED, and people sometimes aren't aware. So recreational drugs, things like alcohol can cause ED. You can take yourself right out of the game just by having too much to drink. It happens. But also excessive drinking over extended periods of time can cause more long-standing problems. hormonal drugs like finasteride. This drug is these kind of drugs are used for a lot of prostate issues, but they can have the unfortunate side effect of decreasing overall testosterone levels. And the same goes for steroids like prednisone, hydrocortisone, and steroids are meds that can be used for a whole lot of different issues, everything from like shortness of breath to having problems with the immune system. Opioids like oxycodone or hydrocodone, these can cause ED, and the risk for experiencing ED on these drugs increases the longer you're taking them, and also with increases in dose. And then another very common group of medications, the antidepressants. These can cause ED as well by they dysregulate some of the neurotransmitters that are involved in sexual arousal. But don't worry, I swear we're not here just to be all doom and gloom. Here to tell you how bad everything is. Next, Steve will go over some of the ways that we can effectively address ED.
Great, thank you, Cavell. And I know it does sound discouraging. The medications that you've been prescribed or the doctor is prescribing, maybe, or you may be worried that may be causing some of these issues. But ED isn't something that you simply have to live with. There are steps we can take to prevent or treat it. The first step is almost always lifestyle changes. The same healthy habits that lower your blood pressure directly improve sexual health. Exercise, just 30 minutes of moderate daily exercise, a brisk walk, is linked to a 20 to 45% reduction in ED risk. Quitting smoking helps restore blood vessel function. A heart healthy diet like the Mediterranean style diet keeps your arteries flexible and clear. Limiting alcohol matters, like Cavell was mentioning. Heavy use damages nerves and decreases testosterone. And again, you always want to manage stress and get good quality sleep. Your body makes testosterone during deep sleep, and chronic stress really blocks that signal that triggers erections. So what you do for your heart, you're also doing for your sexual health, for your erections. But sometimes lifestyle changes aren't enough, or the ED is a direct side effect of a blood pressure medication or one of your medications. And that's really where medication management comes in. First, a doctor could try switching to a different medication. Again, like I was mentioning, not all blood pressure medications affect erections the same way. Sometimes simply switching to a different one often solves the problem without sacrificing blood pressure control. We could try adjusting the dose. Lowering the dose while keeping your blood pressure in range can reduce side effects, especially again if you've made those lifestyle changes we just talked about. And lastly, we could try adding an erectile dysfunction medication. If your blood pressure medication is working well, we can often just add an erectile dysfunction medication. The most popular of which are called the PDE5 or phosphodiesterase 5 inhibitors. These are medications like Viagra and Cialis, and they work by helping those blood vessels in your penis open up more easily during arousal. They are effective. Up to 60 to 80% in the general population of men see good results, and they generally are safe to combine with most blood pressure medications. There is one critical warning on the slide, though. Never combine these with nitrates. If you take nitroglycerin, it's also called nitrostat, or isosorbide dinitrate for heart disease. You absolutely cannot use these. They cause a dangerous, life-threatening drop in blood pressure. But beyond these pills, there are other options your provider can discuss, like there's injectable medications, devices, and other treatments. But really, the big takeaway I have is there's almost always a solution where you don't have to choose between a healthy heart and a healthy sex life. But really, to achieve both, it requires taking the next step, and that next step is commonly having a conversation with your provider. And I just want to share that critical message. If you think that your blood pressure medication or any medication you've been prescribed is causing ED, don't stop taking it on your own. And I know talking about it isn't always easy. You may think that just stopping the pill is the simple fix. If I just stop it, it'll take care of it. But really, uncontrolled blood pressure is dangerous. These medications protect your heart, your kidneys, and your brain. Stopping suddenly can cause your blood pressure to spike. And long term, this will put you at risk for stroke or heart attack. And again, the great irony as before is uncontrolled high blood pressure just keeps on damaging those small blood vessels that control your erection, making your risk of having ED even worse over time. So stopping your medication doesn't solve the problem. It can actually make both problems worse, your heart health and your sexual health. So really the only safe solution is to talk with your provider. And I get it, like I said, it can be awkward. But your provider has heard this many times before. It's common. Cavell mentioned the statistics, by age, between the ages of 40 to 60, 50% of men have experienced erectile dysfunction. So we're here to help. We're not here to judge. You can be direct. You can say something like, I've been having trouble with the erections, starting my blood pressure medication. Could it be related? Are there alternatives we could try instead? And I get it if you're nervous, you can write it down. You can just note when it started, how often it happens, and what medications you're on. And if that face-to-face feels too awkward, you can use a patient portal. I know here at Sentara, we have something called My Chart, where you can send a direct message to your provider. It's discreet and gives you time to think through what you want to say. And also, I don't want to forget this also, a pharmacist is a resource. We're there, we can help identify which medications may be the culprit, and then coordinate with your provider about alternatives or talk to you about what alternatives exist. Because again, here's what I want you to remember. This affects your quality of life. It's important. Your provider knows that. And again, you really don't have to choose between a healthy heart and a healthy sex life, but you do have to take the first step. You do have to start the conversation. So just to quickly summarize what we've covered today, I know it's been a lot. ED is common, especially with high blood pressure. You're not alone. This is biologic. It's not a personal failure. Second, it's often treatable without giving up blood pressure control. We have solutions, switching medications, adjusting doses, or adding erectile dysfunction medications and treatments. Third, don't stop these medications on your own. Talk with your provider. It's really the safest way forward and protects you from heart attack or stroke. And then finally, taking care of your blood pressure really protects your sexual health too. By treating your high blood pressure, you're saving your heart and your sexual function in the long run. All right, thank you.
Might need to get off of mute. Thank you all so much for this information. I know we have some questions that have started rolling in on the chat, and actually, let me fix one of the settings on the chat. Um, so we had the first question that came in, and this question I think is a really great one. It's one that I actually had myself that I wanted to ask. Shouldn't providers be screening for ED, or at least asking about it at each visit, to break the ice since it's such a sensitive topic? And that, and either one of you can give your thoughts on that one. I know it's kind of a hard one.
Yeah, I know that I know it's not something that's mandatory for them to do it. Some of them may, some of them won't. I don't, of course, have any data to back this up. I would be inclined to think a lot of the times maybe a male provider would do it more often than maybe a female provider would. But a lot of the times, because even though we may not think that it's a super normal thing to talk about, they hear it all the time from a whole lot of their patients, and they get to a point to where they can legitimately think that if you're having an issue or a concern that you would actually bring it to them. So as far as shouldn't providers be screening for it, I think that yes, it would be nice, but it's just not likely going to happen because it's not something that's mandatory.
Oh, understood. So another question that I had, given that ED itself is a sign of underlying issues with blood flow and nerve, does the appearance of ED in a man at any stage, particularly an African American man, serve as an urgent warning that his overall cardiovascular health may be worse than he realizes?
Yeah, definitely. Like Steve was saying earlier, so the ED can be presenting as a warning that maybe you're having some constriction or some damage to the blood vessels in the penis, and that can sometimes not be the first place that's being damaged. Actually, a lot of times, if you notice that you're having ED, that can also actually precede having full-blown cardiovascular disease by 3 to 5 years. So it's definitely an early warning for the body. It can even be things like maybe um, sometimes we don't go for checkups as frequently as we're supposed to. So it could be an indication maybe your blood sugar is just out of control and you just have no idea you're walking around because you feel fine. So yes, it can definitely be an indicator that something is going wrong or something is up with your body.
Yeah, you made a great point about we don't go into the doctor as often as we should. I know it basically takes an act of Congress for me to get into the doctor like I should. My wife stays on me, and I mean honestly, I'm sitting here at my desk and my blood pressure medicine is sitting right here. Um, I was happy when we got to the red light, green light side. My medicines were more on the green side with amlodipine and
I agree.
Lysergin. Um, so that was great to see. But if if a patient is doing well on a high risk medication but experiencing ED, what would be the first step you recommend? Or would this be something that they need to see their primary care physician about immediately?
Yeah, I think they really need to see and talk with their provider first, again, before stopping the medication. Because maybe we can dial the dose back, maybe we can reduce it, and that could resolve the side effect, the ED, maybe switching to a different medication. But again, I would get that, I would send that my chart message, send that patient portal message, make that phone call, reach out, or talk to the pharmacist. The pharmacist a lot of the times is the most accessible healthcare person. So if you're friendly with your pharmacist, I know pharmacists are always friendly, so we're there to talk to you. So, reach out to us. Hey, could this medication be causing this issue? What do you think? You could definitely start there.
Yeah, no, that's a great point. Now, Steve, you detailed like how the PDE5 inhibitors like Viagra and Cialis work to enhance blood flow during
hmm
arousal. Men who are concerned about sexual health, why is it critically important for them to never combine ED treatments with nitrates? You called it out, and I just wanted to come back to that as being something that was critical.
Yeah, taking the nitrates and Viagra, the PDE5 inhibitors, can cause a really great reduction in blood pressure, so much so that it can be life-threatening in some cases. So it's really vitally important not to combine those two if you are taking a nitrate for chest pain or for heart disease.
Okay, no, that makes sense. Now, Cavell, question for you. Um, the presentation touched on you can tell I don't work on the pharmacy side because these are some large words. But it touched on
I swear they go out of their ways to make the work the medications as complicated as possible.
they really do. So it's aldosterone um, antagonists, which have a risk of causing ED. For patients taking difficult to treat blood pressure or heart failure, or taking this. Okay, let me ask it again. For patients taking this for difficult to treat blood pressure, and heart failure, are there specific side effects that these medications, uh, beyond ED, such as hormone changes, that men should be aware of, or is there any signs they should be looking for when they're taking those medicines?
Yeah, so outside of ED, some of the more common ones you want to look for is you want to make sure that you're keeping up with your labs because it can also cause your potassium levels to go higher. But then also something that you definitely want to look at, especially if you're taking spironolactone, is it's what's called gynecomastia, but it's really like essentially the development of more feminizing features, and usually it's like developing breasts, which is a potential side effect of spironolactone specifically.
Yeah, I mean, one of the motifs I keep hearing is basically if something doesn't feel right, go see your doctor. If something seems like it's changing, go see your doctor. That there really is an excuse just to accept it until you're at the point that you have to accept it. So I think that's great. That's great feedback. And we do want to remind those who have joined us in the Zoom, or we were having some issues with the live earlier, so I think the live came back up now. But we do have a good number of people here in the Zoom as well. You're welcome to add questions into the chat functionality, so that our two guests can address those questions. Um, so one additional question I had, and this can go to either one of you. Um, since African American men are disproportionately impacted by severe hypertension, does that mean they're often prescribed older or higher risk medications due to the severity of their condition? Or, and if so, can a patient advocate for a neutral positive option like the newer beta blocker that you mentioned?
Yeah, they can definitely advocate and take an active role in their treatment plan. Nobody should give them a hard time with that. As far as what they're not necessarily, there are certain guideline directed standard of care medications that people would get started on first, and it really are the most effective options. And those are usually from either the ACE inhibitors like lisinopril, the ARBs like losartan, calcium channel blockers like amlodipine, or the thiazides like hydrochlorothiazide. Those are the four main and most effective classes of medications for hypertension, high blood pressure. Usually, you don't get to the spironolactones and the beta blockers until much later down the line, because even when we start you off on one, let's say that's not working. If we add another one, it's going to be one from those first four classes as well, because those are the best ones. So it takes a while for you to get to the point to where you're doing some more of the second line options.
Yeah, you make a great point about sometimes needing to change dosages or go to two medicines. And we actually have a question that kind of asks about that. Are there particular medications that are more effective in Black men? And are two different meds usually needed?
Um, Two different meds are oftentimes needed. So what it is, it really depends on how your high blood pressure first presents. So hypertension, which is high blood pressure, um, the way that it's classified, it starts when you're trying not to get overly technical, but your blood pressure has two readings, your systolic and your diastolic. When your systolic, which is the top number, is 130 to 139, that's considered stage one hypertension. Once it gets over to 140, that's considered stage two hypertension. If you're in stage one hypertension, depending on depending on any other comorbidities or other conditions you may have, they're likely, if they start you on a blood pressure medication, it's going to be one medication. But if you're coming in at stage two or higher, that's when they'll initially start you off on two medications from the go.
No, that definitely makes sense. And as much as we're talking about the medications and the importance of the medications, I know there was one slide in particular that I have the hardest part or the hardest time with personally, but I think is probably some of the most critical. And it was talking about the other lifestyle changes that we could and should do. Um, going back to what is it, slide 19 or so? um,
Yes.
the exercise, the quit smoking, the eating a healthy diet, limiting alcohol, managing stress, getting quality sleep. And I look at that and I'm like, man, I don't know if I'm hitting maybe one out of those six right now. Um,
I can tell you
I'm
right now,
trying.
I'm not hitting all six, but you can only do, you can do
Yeah.
the best that you can do.
Yeah, and it's not an all or nothing thing either. I know I had said 30 minutes of aerobic exercise every day, but it can be, 10 minutes after breakfast, lunch, and dinner. It doesn't have to be something formal either. It doesn't have to be jumping on the elliptical, every morning at 5 a.m. It can be, hey, I like doing yard work, doing some yard work, just getting that heart pumping and getting the blood moving, just trying to make better choices over time. So it's not an either or all of one or all of the other. It can be, just doing better over time too, I think can help.
I mean, and as it relates to this conversation, sexual health is an important part of health, even outside of just the pleasure factor. It does increase hormones and gets the heart pumping a little bit. So it's another good reason, full circle, in this discussion. So we did have another question. How does, as we're talking about this from a pharmacy or pharmaceutical standpoint, but how does age play into ED? Um,
Yeah, so that's something that, as time goes, becomes more and more prevalent. So the estimates are, and in our 40s, about 40% of men will experience at least some form of ED. It might not be complete, it might be inconsistent, it might be partial, but you start seeing it more in our 40s. And then as with each decade goes on, it becomes more and more prevalent. So in our 50s, about half of us will experience it. In our 60s, about 60%. By the time we're in our 70s, the vast majority of us will have experienced at least some form of ED.
So, I mean, with you saying that, it's, I know we started talking about the fact that it's not something that's talked about, but it's something you shouldn't necessarily be ashamed of. It is part of aging. And that's why, again, going to your doctor, expressing concerns, notifying them of changes becomes critical. So no, that's a great point. Shout out to everyone who's in their 40s and 50s. All of us born in the 70s and earlier. I say I'm an 80s baby, but I was born in 79, so it's technically the 70s as I'm aging myself here.
Hey, you're one
Um,
of us.
yeah, I'm
Yeah.
right there. I'm right there. It's I don't wear a baldy by choice. Put it that way. Put it that way. So we, we talk about we covered so much in this conversation today. Um, can you talk a little bit more about? You mentioned earlier about not stopping your medication. Can you stop? Can you talk a little bit more about this abrupt stopping and what could cause dangerous blood pressure spikes?
Yeah, if you stop your medication again, you won't have that regulation to control your blood pressure. You've in some cases, depending on how long the medication works in the body, that could gradually wear off after hours in some cases, depending on the medication, or it could wear off, over a couple of days. But ultimately it's not having that blood pressure controlled, that can place you at risk of having strokes and heart attacks and various cardiovascular issues. So really it's important to again not stop those medications right away. In some cases, in some medications, it can actually cause a rebound hypertension where your blood pressure can actually go up if you stop taking it abruptly. So it's important not to just willy-nilly just go ahead and stop it. In a lot of cases, again, it's breaching that conversation, talking with your provider. I'm having this issue. Can we think about putting me on something else? And doing that switch in a more of a transition, a gradual transition, if you need to.
Yeah. So I mean, we talk about those abrupt stops, and that's just stopping altogether.
Hmm.
What about those of us who have very busy lifestyles and I'm running a little bit behind in the morning. I ran out of the house. I forgot to take my medications. What does the occasional, we'll use the term occasional right now, are forgetting to take your medication? I know I've had a 90-day supply that's lasted me probably close to 180 days before. And maybe not quite that long, maybe 120, but where I'm getting those reminders that it's time to pick it up. I'm like, but wait, I still have half a bottle left. Um, how does missing your medication affect you?
I would say it depends highly on the frequency of the missing, because we follow up with a lot of patients for like adherence issues. So if you're missing it every now and then, it's going to be fine. Like the effects from long-standing hypertension, they take a while to really come into play, which is a good thing, but it's also why people underestimate it sometimes, because you're not seeing the effects so quickly. Um, but it can, like I said, it depends on how frequently you're missing. If you're missing one every now and then, I would say if a 90-day supply is lasting 180 days, you're probably missing it a little too much. It's probably
Yeah.
a little aggressive. Like you have a 50% batting average over there. But yeah, 50% missing it half the time is I would say that that's too much. But missing it every now and then is just natural. Nobody's going
Yeah.
to remember to take it
Yeah.
every single
Life
day. That's
happens
just
sometimes.
yeah, that's an unrealistic expectation for like 100% adherence. But it's you just want to minimize how much you are missing.
I mean, I laugh because I'm doing much better. You guys should be proud of me. I maybe miss once every few weeks, but I have supplies, strategic places in case I forgot going out the door, and I just open the desk and there's another supply there. But as we talk about the um, the lifestyle changes and the medication, one of the things I find interesting is there's also certain foods and things that counteract. the effects of the blood pressure medicine. When I was in the Army, I remember we had a drill sergeant who, when it was breakfast time, we weren't allowed to eat. All we were allowed to have is 2 glasses of grapefruit juice. And I grew a love and an affection for grapefruit juice. And I hit about 38, 39, and they're like, yeah, you need to get on these medicines. And most importantly, don't eat grapefruits or drink grapefruit juice while you're on it. Are there any other like things that you wouldn't perceive as unhealthy? I guess that's not the right word. But any other things that you should avoid that you could perceive as healthy lifestyles that could affect you when it comes to both blood pressure or ED? That's a hard one right there.
Yeah. So you're saying more so like dietary considerations to take?
Yeah,
Yeah.
yeah, definitely.
I would like to shout out whoever warned you about not doing the grapefruit juice, because that one flies under the radar a lot more frequently than you might actually think.
I
Yeah,
love
As far
grapefruit juice.
yeah,
that's an
that's
important one.
that's odd to me
Yeah.
because but, very quick side story. My father actually likes grapefruit juice as well. When I was younger, one time he got sent home on a prescription. Nobody gave him that warning, and it was one of those ones where the medication interacted with grapefruit juice, and he like had a hard time getting up. Um, um, so that's why I commend on whoever told you. I always look out for that one. But for the things like blood pressure, as far as diet's concerned, one thing that does sneak up on people who are just trying to do the right thing would be something like beets or beet juice, because it can naturally lower your blood pressure, and it can be pretty intense. Like if you take a beet and grind it up and put it in your smoothie and you drink it, you don't want to just go for a run immediately right after, because it can cause a noticeable decrease in your blood pressure, and you don't want to um, if you're taking blood pressure medication to control it, there is also always the risk of it going too low. You don't want if you start feeling dizzy, lightheaded. These are just things that you want to be mindful of. So that is one that definitely sneaks up on people. Outside of that, that can on the opposite end of the spectrum in regard to blood pressure is going to be foods that are usually higher in salt, because sodium intake, which oftentimes is a problem in the Black community, is we like our seasoning, and they just load it on up in there, and so the easiest way that I describe it is the water goes wherever the salt is. So if you have a lot of salt in your body, you're going to retain more water, and that retained water increases your blood pressure, and so that you can get into trouble that way. That's also a lifestyle modification that always works to get ahead of high blood pressure. If you, let's say, you're nervous or adverse to start getting started on medications, that's just not your thing. There are other ways to go about it, and one of the first ways that you're always going to be counseled on is going to be to decrease your sodium intake.
So that's interesting because if I'm not mistaken, is it Lacertin that is a water pill? So what does that do? Um, does that cause you to release the water? I take it then, so that you're not retaining the water.
Yeah, those would be the thiazides, hydrochlorothiazide, chlorthalidone. Yeah, those cause you to urinate and release fluid. Before there was a time where for African American males, those were preferred just because that we tend to have a lot more issues with water retention. A lot of it is dietary related, but they did find over time as they watched that there wasn't really any net benefit to avoiding some of the other ones. So that's not necessarily a strong recommendation anymore. But yes, they
Oh,
do increase the frequency of urination.
yeah, I tell you, you all know the office I work in, and it just so happens that my office is literally as far as possible away from the men's bathroom. And I try to get close to a gallon of water each day, and I try to take my meds. So it makes for a long day, and I get my steps in
Yeah,
part
get your steps
because
in.
of the fact that I'm walking all the way to the opposite end of the building. I walk past 2 women's restrooms, though, on my way there, which makes me feel some kind of way. Um, yeah, but so that's a great point. And we do have some comments about the juices and items and staying away from certain things while on meds. So I'm glad we did bring that up as a topic tonight. And to that point, I didn't like grapefruit juice until I got in the Army. and they kind of, beat ahead
That's when it
by
started.
saying this is all you're allowed to have, and became something I for the next 10 or 15 so years. Um,
Yeah, not
so
having to do with blood
here's a
pressure
question, and
medications specifically,
oh, I'm
but
sorry.
actually not having to do with blood pressure medications specifically, but having to do with Viagra. A high fat meal can actually reduce the absorption of Viagra. So if you've ever tried it or going to try it, if you eat it with a high fat meal, it can actually reduce the absorption and prolong the onset where it takes longer to work. So that's also kind of a drug food interaction you should watch out for.
Wow. Yeah, it's you don't often think about the foods and how they
No,
interact with this drug. And as you say,
exactly.
fats are is that all fats or is that just like the bad fats? Because like I'm loving salmon and like I'm trying to eat healthy on the fish side and stuff like that. Would those be the type of things to stay away from as well, and then be more on my vegan pick for that day?
So those are heart healthy things you definitely should do, but I would try and maybe eat those on a day that you may not take the Viagra. There are the other medications, like Cialis, for instance, doesn't have that same drug food interaction, but
Hmm.
Viagra specifically does. So even though it's, even though salmon's healthy, it still has that fat in it, especially if you eat a large amount, it can reduce that absorption. So yeah, just something to watch for.
Yeah, that's great. That's great feedback because in my mind it's healthy. It's kind of like the point we were saying earlier that take the healthy stuff is going to help me, but not in all ways. Um, so we talked about missing medicine. What if you're having a day and your blood pressure is running a little high? Can you double up on your pills? Like would that work or like to bring my blood pressure down or if I'm seeing a spike, is that an instance where I need to go in and see a doctor immediately and not just pop an extra pill?
Yeah, I would recommend reaching out to even if you're doing it electronically, like Steve was saying, with the technology that we have today, you can reach out to them through things like MyChart, at least with Sentara, if you need to for something sudden. I would try to avoid self-medicating because let's say, for example, like these medications come in different strengths. Let's say you're on lisinopril. Let's say your blood pressure is running a little bit high. It comes in different strengths, so 40 milligrams maybe like the highest dose. Let's say you're on um, 20 milligrams a day, 40 milligram is the highest dose. Let's say you decide to double up and now you're taking 40, whereas maybe your provider might want to put you on a dose in between, something like 30 milligrams. So when you start self-medicating, you do run the risks of over-medicating as well. And so it is something that I would counsel against doing on your own and more so in conjunction with your provider, your physician.
Right. You may need that higher dose. So yeah, definitely talk with your provider.
And I mean, I've had a similar conversation with my provider. It's kind of like a dance. Like you have to also your labs are going to be monitored to see how your body's being affected by it because overdosing on some of these things can cause other problems. Um, so I guess that's the other big part why you don't want to self-medicate. You don't want to just pop twice the pills. Maybe you just need to go get some beet juice. That's one thing I don't like. Beet juice does not taste good. No
Beet juice
matter
does
what,
not taste
No.
it does not.
No.
Uh, it's made to go in smoothies. I'm letting everyone know
good.
there's some good gummies out there that have I want to say it has another fruit mixed in, but I'm still not to that point where my grandmother loved her pickled beets or her beets and everything like that. And no,
Right.
those some scars will never go away.
Right. And speaking of scars, another really quick side story regarding my father again. He would crush up beets and make beet juice, and then he would put beet juice inside of the grapefruit juice container. So you would pour yourself a tall glass of grape juice and take a confident swig and almost vomit. So yeah, yeah. Speaking of scars.
So I wonder if that would work for me though. So like the beet juice would bring me down, and the grapefruit juice would bring me back up, but it just would taste horrible. No, that's great. So great stat that someone just shared in the chat. Studies showing that 72% of men are too embarrassed to bring up ED to their providers. How do we encourage patients to discuss this? Like what can we do? I mean, I appreciate everyone who jumped on the Zoom tonight, everyone who came onto the live, those who are watching this video later on. We're taking that first step. What can we do to making this a normal conversation, something for people not to be afraid to talk about.
Well, I think first of all, it's kind of reframing it in your head, right? It's often not a personal failing. It's a biologic issue. It's a blood flow issue. It's a nerve issue. It's a hormone issue. So it's not a personal failing. And then kind of shifting that, reframing that conversation to it's also like I was saying, a blood flow issue. So it's a cardiovascular issue in some cases. So it's a warning sign that you do need to bring up with your provider. So it's not a personal failing. Sexual health is important, but so is heart health, and they're really both combined in a lot of cases. So I think just making that mental shift in your head, hopefully will help kind of bridge that gap and break that tension.
And I also think people really underestimate just how commonly their physicians hear this from people. So it's
Mhm.
I in our own heads, we can sometimes make what is it, a mountain, what is it, what's the saying? I make a mountain out of a molehill. I don't know the
Molehill.
saying, but you,
Yes.
you know what I'm trying to say. But your physicians, your PCPs, they hear these things all the time. It's not uncommon to them at least. So the apprehension that you're feeling is generally on our side more so than the healthcare providers.
Yeah, and I think one of the key points that also is trying to be made with this question too is I think some of the responsibility falls on us as healthcare professionals as well. Um, though it's not the reason they're coming to see us. It's within the things that we should bring up to them, especially as they start meeting certain criteria. They're in a certain area that's more likely to face some of these concerns. I'll even take it on the shoulders of organizations like mine. When we had some technical issues earlier, my chapter president came on and he was at the barbershop. Well, while he was at the barbershop, he shared out the link for this and told them, like, hey, if you can't watch it tonight, we're going to have it posted on our YouTube and Facebook and Instagram within 24 hours. So check it there. I think we have to become champions for this, even outside of just at the doctor's office. It needs to become the conversation that we have, whether it's at the barbershops, at church, when we're leaving the gym. Like it's the type of things that all too often we don't discuss because, to your point, we think it may just be us. We don't realize how common it may be. So it gives me hope just that Sentara decided to have this conversation, that Sentara wanted to partner with us on this because what are we? We're about 2 weeks away from Men's Health Month. So there's so many topics we could talk about because there's so much that we often forget to take care of in our bodies. I mean, I so okay, I'm gonna show how I'm a bad person again. I was supposed to have a colonoscopy today. I canceled it because I had some meetings that I needed to take, and then, but most importantly, did reschedule it. But that's one of those things that you know it hasn't been high on my list to get done.
Mhm.
You're not
And
thrilled about
and
it.
not too thrilled, but in one of my in
Right.
one of my chats, it's about eight guys around my age, give or take a few years, all African American men. One guy, one guy got his done and then talked about it,
Right.
and that
Mhm.
kind of broke down that wall, and then it became a long. It went from being a chat to a long conversation about
Hmm.
Mhm.
how did it feel? Like, what were you able to do afterwards? And sharing his feedback is also the reason I was like, oh, I have stuff to do tonight. Like I don't want to be drowsy or anything like that. I need to be lucid while I host this talk on Zoom tonight. So it was just things like that I think are going to become critical. You
Yeah.
know,
I think that at least in my experience, like if you're ever experiencing something or have a question or unsure of something, you're usually not the only one. And sometimes it just takes that one person to speak up, like in your instance. And I know a lot of the times for us fellas, like I think the ladies have us beat by far. Like they just like they talk about everything with their with their girlfriends. Nothing's off limit, and so a lot of things get brought up, and they actually help take care of each other, whether or not they're trying to. And that's something that it would be, I think, extremely beneficial if we could normalize more so, at least amongst our fellas.
yeah, and I'm excited. This is the start. of a relationship. I'm looking forward to having you guys back in the future, bringing in other healthcare professionals, and talking about some of the things that we often don't talk about. You know, I was at a conference this last weekend where there was a couple of hundred Black women, and a lot of their topics were around health. It was around mammograms. It was around the things they need to do, and then it was our sister sorority Zeta Phi Beta, and though at one point they were talking about it for them helping the community, there were also sessions where they talked about it for themselves, where they're like,
Mhm.
that's the stuff
Mhm.
we need to do so that we can in turn help others in the future. So I think that it's empowering. That makes me say, well, why not us? Why can't we have these same conversations?
All
Um,
right.
a great We had a great comment in the chat. They- they- uh, it's an individual who's doing their doctoral study on the importance of provider screenings for patients in ED to break the ice and create a more comfortable environment to discuss it, rather than stop blood pressure meds. So I think that there's so much opportunity. Um, I know that my doctor, I felt, you know, you're going to be very vulnerable when you find a doctor, especially a doctor you're comfortable with.
Mhm.
Drive 45 minutes, oh, basically in Moya, way out there in Edinburgh, and I live in Oxford. But I found a young African American male doctor, it was the thing that was going to make me feel comfortable. Um, Given
Mhm.
my health history, my blood pressure issues, I wanted someone who could relate, someone who had overly seasoned food growing up, who knows what it's like to say, but everyone else is eating that fried fish. I want to eat that fried fish right now too. So I've been willing to make that extra bit of a drive. So I think it's important that as we're all an older generation that's on this call, but we need to impart upon those next generations that healthcare is something that it's important to have a diverse uh, field of doctors, of pharmacy professionals. Cavell, you went to Hampton Institute, which has probably one of the best pharmacy programs in the country, um, over there at your home by the sea. And they put out an amazing number of there's a pharmacy every year. So I think that it's happening. Like, we need to make sure we put a spotlight on this and show that anyone, or that we need everyone to be represented in our professionals so that everyone feels comfortable having these type of conversations. We
Sure.
are coming up close to the end of the hour. So, I mean, with that, I want to pass it to you all to have any closing remarks you may have.
I would just close things out, just reiterating some of the points made earlier. Um, don't be ashamed. Bring it up, like you were saying. It's worth the effort to normalize these conversations amongst the fellas. If I had to leave you with one or two things that I would regard as a strong recommendation, I would say if you're not doing it already, exercise never hurts. And trying to, I'm really focusing on things that I've tried focusing on and I've seen the results for, and so I can speak to them more recently. So exercise and cutting down on the salt. If that's not something you're doing now, to at least make an effort towards it.
Great, thank you. And Steve, any final
Ye-
closing thoughts or call to actions
y-
for the group?
Yeah, definitely. So I would say ED, it's not a personal failure. You're not alone. You saw the statistics today. If you're experiencing ED, take that step, make that first step today. Reach out to your provider, check your blood pressure. Make that appointment for the blood pressure check if you need to, but take that first step.
So thank you both. I mean, and I want to close it out by saying, this was a great first step for so many of us today. Jumping on this call, being brave enough to jump on this call. A lot of people saw the topic and they were like, wow, you guys are going to talk about that? Well, yeah, we are. So I appreciate everyone who decided to join us today. Um, there was a ton of great information shared, and we must realize that health is our priority. as fathers, as sons, as husbands, we need to be here. And we can't be here unless we take care of ourselves, and take care of ourselves physically. Um, if you're struggling with any of these issues, please talk with your doctors. To all my Sigma brothers that are on tonight, and all other men in the African American community, especially, let's make a commitment to prioritize our health. We cannot serve our communities if we don't take care of ourselves. I think tonight was a great start. It's a great conversation, and I look forward to continuing this. So again, thank you to everyone who joined in tonight, and we look forward to engaging with you all next month with our next topic. So have a great evening, everyone.
All right. Thank you, sir.
Thank you.
Thank you.